last session before lunch. We shall have another half in our session. And to do this session, may I please invite on stage Dr. Ajit Menon, MBBS, MD, DM, FS, CAI, ranked first in the college at the MD examinations held in Jan 1989, ranked first in the University of Bombay in the DM cardiology examinations held in October 91. He has a wide range of experience, invited as faculty for Malaysian Life Conference in 2007, as international faculty for TCT San Francisco, USA 2011, international faculty for Euro PCR, organizing secretary for India Live 2011, Mumbai, India. He's been invited as faculty for India Live 2012, 13, 14, and 15, member of Indian College of Cardiology, ICC, member of Cardiological Society of India, CSI, member of European Society of Cardiology, ESC, awarded fellowship in the Society for Cardiovascular Angiography and Interventions, FSCAI. To do the honors for felicitating him, may I please invite on stage Dr. Gajendra Yadav. May I please have you on stage, sir. To talk about recent trend in cardiology, ladies and gentlemen, Dr. Ajit Menon.
Yeah. Good afternoon, everyone. Let me at the outset thank the committee members, Dr. Suvin Shetty of the Association of Practicing Pathologists for having me over, and most of all to Roche also for this privilege. I was asked to talk on recent advances in cardiology. Basically, I mean, when I thought when I'm talking to a group of pathologists, I'll dwell on something which both of us interact with on a regular basis, and that's in our field, that's basically cardiac biomarkers. Now, if you try to define a cardiac biomarker, it's basically the official NIH definition of a biomarker is something which is objectively measured and evaluated as a predictor of normal biologic process, a pathologic process, or it's a pharmacological response to a therapeutic intervention. If you look at the medical dictionaries, it mentions it as an analyte, which is measured in serum, which reflects myocardial damage or acute cardiovascular disease. Another definition for it is which is substance which is released from the heart muscle when it is damaged or as a result of myocardial infarction. Cardiac biomarkers therefore represent some substance which is released subsequent to leakage of cell contents from the myocytes following an acute myocardial injury, whether it's an acute ischemia, whether it is a acute myocardial infarction, or any other damage to the cardiac muscle, which makes the muscle lose its integrity, can have a potential to release these biomarkers into the circulation. But it's not to be used alone. It's always used in conjunction with the ECG, history, a medical examination, and the clinical findings of the patient. Going back to the history of biomarkers, one of the first biomarkers that was introduced was, of course, the aspartate transaminase as SGOT. And subsequently, over the years, it has seen a progression. And we have multiple biomarkers coming in over the last few years. The latest one that has come in is the troponin I, which today is probably the gold standard in terms of diagnosing coronary disease, and one of the best markers amongst these for the potential diagnosis of an acute coronary event. What is a perfect cardiac marker? We still are in search for it. A perfect marker is still which makes an early appearance. We should be able to diagnose within a few minutes of the injury. Something which is accurate, specific, and precise, readily available, fast results, and cost-effective. What are the uses of biomarkers in clinical practice? One, of course, is the diagnosis of acute coronary syndrome, diagnosis of acute heart failure, prognostication of patients with cardiac failure. I'll come to these topics in the next few slides. Diagnosis of pulmonary embolism. That's usually not very commonly seen, but we do these investigations in pulmonary embolism. And the presence of these biomarkers in pulmonary embolism is usually because of a right ventricular strain or a right ventricular overload in these patients. Optimal management of patients. We can do serial biomarkers to see how the patient progresses. Screening of patients with vague symptoms. Detection of chemotherapy-associated cardiomyopathies. Prognostication and cardiovascular risk in end-stage renal heart failure. And of course, prevention of cardiac diseases, whereby there are a lot of new genomic biomarkers coming in, which probably predict the possibility of someone getting a coronary heart disease. The list of biomarkers is exhaustive. We have troponin T and I, we have creatine kinase, the MB subfraction, we have lactate dehydrogenase, SGOT of course is there, and we have 3 new markers which have been used now recently the last couple of years, and we are being used more and more. One of course is myoglobin. Then you have the pro-brain natriuretic peptide, the pro-BNP, the heart fatty acid binding protein. The last 3 are not commonly used, but they are approved for diagnosis of acute coronary events. That's ischemia-modified albumin, glycogen phosphorylase isoenzyme, the BB subfraction, and interleukin-6. Cardiac biomarkers are an integral part of the most recent joint ACC-ESC guidelines on the definition of a recent or acute MI, which basically states that a typical rise and gradual fall, that's troponin, or a rapid rise and fall, which is CK and CKMB, or biochemical markers of myocardial necrosis associated with at least one of the following. That's ischemic symptoms, development of pathologic Q waves, ST segment elevation or depression, and coronary intervention. So you can see that when a patient coming with just one chest pain, which is we think is classical of angina, if we have a biomarker which helps us diagnose this condition, that yes, this biomarker being positive, it is definitely ischemia. This biomarker being negative, it is unlikely to be ischemia. That goes a long way in management of these patients. But unfortunately, most of our biomarkers have a gap of at least 2 to 3 hours by the time they become positive. And the ones that become positive early have a low specificity also. Let's talk about certain of the biomarkers. Troponin T and troponin I basically control the calcium-mediated interaction of actin and myosin. Troponin I is very specific for the heart. Troponin T is not. Troponin T can be increased in a lot of conditions, including sepsis, other muscle injury, and chronic renal disease. So it's not a very specific diagnostic element as far as acute coronary syndromes are concerned. So we believe in troponin I. Troponin T is an additive. If both are positive, it's fine. But a troponin T being positive in the presence of other associated abnormalities may not be very specific as a cardiac biomarker. Troponins are the preferred biomarkers for diagnosis of acute MI and is a class 1 recommendation. But one thing that we do emphasize on and we see in our clinical practice also, we have an patient with ST elevation MI, and we see doctors still waiting for the troponin reports to come in. Of course, we do have the rapid test which tell us the troponins in a matter of few minutes, but in labs where they wait for an hour or 2 for the troponins to come in is not to be done. So basically, if you have a patient with an ST elevation MI, we do not look for the troponins. But the downside of it is that even in an ST elevation MI, a lot of us forget to do the troponins. A lot of us forget to do the cardiac enzymes. Well, there's nothing wrong in it, unless the patient is heading for a worse scenario. But if anyone is insured medically or in terms of life insurance, the diagnosis of acute MI is not based upon the ECG. They need the cardiac biomarkers also. So unless you have a cardiac biomarker, an insurance company does not release your payments. So a cardiac biomarker being positive, documented, even in an ST elevation MI, is an absolute necessity. This is a classical curve that we see, where we see that myoglobin is the first one to increase. Can I have a pointer, please? The green one, okay. Okay, the myoglobin is the one that actually increases the fastest, rapidly comes down. The troponins remain high for a much longer period of time and can be detected in the blood even 2 to 3 weeks after the initial coronary insult. So a troponin I or a troponin T is good for diagnosing infarcts in the previous 2 weeks. It doesn't tell you the exact limit. CKMB rises within the first 4 to 6 hours, goes up and comes down within 5 days, the CKMB reaches normal. So troponins increase in about 4 to 6 hours post-infarct, 6 to 9 hours to detect pathological elevations in all patients, And it can persist in the blood for a few weeks, thereby make the cardiac specificity of troponins makes them the ideal markers for retrospective diagnosis of acute infarcts. A meta-analysis of about 21 studies with 20,000 patients with acute coronary syndrome revealed that those patients who have a high troponin have a higher incidence of cardiac death and reinfarction at the end of 30 days. So the level of rise of troponin directly correlates with the in-hospital mortality and the initial 30-day mortality in patients with acute coronary syndrome. The GUSTO-4 ACS study was one of the studies which basically underscored the importance of the degree of troponin elevation. They divided the patients into 4 quartiles depending upon the extent of elevation, going up from 1 to 9 nanograms. And what they did find was that the 30-day mortality increased from 1.1 to 7.4% from the first to the 4th quartiles as the levels of troponins were much higher. CK isoenzymes have been a force of investigation for a long time. What we are interested in is the CK-MB, which is basically from myocardium and skeletal muscle. But again, there is an interference with skeletal muscle also. High specificity for cardiac tissue, preferred marker for cardiac injury for many years, rises 4 to 6 hours after infarction, but can take up to 12 hours to become elevated in all patients. Elevations return to baseline in about 36 to 48 hours in contrast to troponins. But if you look at the CPK-MB alone, the CPK-MB alone can be increased also in patients with skeletal injury. We have patients who come in with intramuscular injections. And when you see the CPK-MB levels in these, the CPK-MB levels are high. So does that mean that that the symptoms are coronary or cardiac? May not be. But if you compare the ratios of the CK to the CK-MB, any ratio which is high, between 2.5 to 5, initially, and they say beyond 4 is highly specific as far as cardiac injury is concerned. CK-MB is a good marker for reinfarction. Why? Because it rises and falls down. So a patient who has a reinfarction 5 to 6 days post-MI, if there's a second surge in the CPK levels, that means that this patient had a repeat myocardial infarction or a repeat episode of ischemia or a repeat episode of an acute coronary syndrome. So CPK-MB as a marker for the diagnosis of reinfarction after an infarct, STEMI, angioplasty, or CABG is an excellent marker. So, but at the same time, you need to have ECG criteria, ECG changes, pain, all the symptoms to sort of classify them into a reinfarction. The shortcomings, like I said, is skeletal muscle injury, and also post-CPR defibrillation, cardiac or non-cardiac procedures, blunt chest trauma, cocaine abuse. These are the most commonly false positive as far as a CK-MB is concerned. What about myoglobin? It has an extremely low specificity for myocardial infarction, but it's the fastest to go up. It reaches up within about 2 hours. Rapidly rising and falling early in that of CPK-MB or TROP-T. Also used to assess reperfusion after thrombolysis, but because after thrombolysis, because of the loss of integrity of the muscle following an acute infarct, the rise and fall is much more faster. What about glycogen phosphorylase isoenzyme BB? It's a high sensitivity and specificity. It's not done here regularly for early detection of myocardial ischemia, one of the newer cardiac markers. It's an isoenzyme of glycogen phosphorylase, which is found in the heart and brain. This is basically during ischemia, the glycogen phosphorylase is converted into a soluble form and released in circulation, and peak levels come up in about 7 hours after the initial insult. This is another investigation which is being done regularly in a lot of hospitals. Heart-type fatty acid binding protein. Following myocardial necrosis, this can be detected in the circulation within an hour. Peaks in 4 hours, becomes undetectable in about 24 to 36 hours. More specific than myoglobin, and superior to troponins in early detection. It does not replace troponins, but in early detection of myocardial necrosis, it is a tool. So we have started doing this in a couple of our hospitals, and we are trying to evaluate what is the sensitivity and specificity in our populations. LDH is something which is good, which is a marker for a long term, in the longer term. It rises typically a little late. Peak levels are about 72 hours, normalizes in about 10 to 14 days. There are 2 isoenzymes, the LDH1 and the LDH2. What we need to see is the ratio of the LDH1 to LDH2. If it is normal, is about 4.47 to 0.74. Anything more than 1 is highly suggestive of myocardial infarction, again, because LDH is not specific for the myocardial muscle. It's basically for any skeletal muscle. What is ischemia-modified albumin? Ischemia-modified albumin has a low specificity for for detecting cardiac disease. It's been approved by the FDA for clinical use. It basically works on the principle that myocardial ischemia alters the N-terminus of albumin, which reduces its capacity to bind to cobalt. And therefore, basically the test that it is used is called as an albumin-cobalt binding test. It must be used in conjunction with ECGs and physical examinations. Low specificity, 45 to 65%, false positive in cirrhosis, infections, and in advanced cancers. We come to another topic, which is natriuretic peptides, which again has been quite widely used nowadays, and we use it quite frequently, not in the detection of ischemic heart disease, but in the in detection, management, and prognostication of cardiac failures. What we are interested in is the BNP, or the brain natriuretic peptide, which is a marker of ventricular overload. It's not a marker of cardiac failure, it's a marker of ventricular stretch or ventricular overload. Therefore, it's basically either in response to volume or in response to a pressure overload. Both of these can increase the BNP levels. So BNP is basically a marker of ventricular stretch. It does not mean anything more than that. It first came in 2000 with a study called the breathing not properly study, which evaluated about 1,500 odd patients who presented to the emergency room with acute dyspnea. And they found that the predictive value of a BNP was much higher than to the other scores like the Framingham score or radiographic criteria or clinical examinations. What it did find from the study was that they reduced the time and the resources needed to diagnose heart failure. The plasma concentration of BNP directly correlated with the NYHA classification of those patients. Not only that, it also detected heart failure due to diastolic dysfunction, though it could not differentiate it from systolic dysfunction. When you have diastolic dysfunction, it's basically a stretch of the heart secondary to a increased stiffness of the heart muscle. And that's what denotes diastolic dysfunction. Therefore, BNP levels are increased in patients with heart failure. It's approved as a marker of cardiac failure. The levels range is normally between 1 and 100 picograms. In a patient who comes in with symptoms of breathlessness, a value which is less than 100 rules out heart failure with a negative predictive value of almost 95%. In a patient who comes in with symptoms of breathlessness and the value is more than 400, the predictive value is almost 95%. Is almost 95%. We have something also called as an NT-proBNP. And N-terminal proBNP is basically an inactive precursor of BNP. It stays in the blood much more longer, has a longer half-life. And it's detectable, therefore, it's detectable in the serum for a longer duration. Again, here, the only point that we need to note is that the NT-proBNP values differ depending upon the age. So a person who's 75 has a different cutoff value for NT-proBNP than a person who's about 30 or 35 and has a raised proBNP value. So these are the values that are given as cutoffs in terms of detecting heart failure. Normal is less than 300. But as the age advances, even a level of 1,800 in a 75-year-old gentleman is a normal value as far as NT-proBNP is concerned. What are the normal actions of BNP? BNP is a normal natriuretic peptide. It is there in the blood. What it does, it causes natriuresis, it causes vasodilatation, and diuresis. These which are all necessary in patients with cardiac failure. So an increase in the BNP is a physiological effect to a cardiac failure patient. It actually helps a patient to subsist through the cardiac failure. It counteracts the actions on the renin-angiotensin-aldosterone axis. Natriuretic peptides are synthesized and released in response to ventricular stress, and very little is stored in the form of granules. Therefore, a patient who comes in with an acute LVF may still have a normal BNP value, because it takes time for the BNP values to increase and the BNP values to reflect in the serum. So a patient comes in with acute flash pulmonary edema may not have a BNP value which is raised. So it's not that we go purely by this to diagnose cardiac failure or stretch. There are a lot of other roles of BNP. One, of course, is to detect and treat patients with congestive heart failure coronary artery disease and atrial fibrillation. There are a couple of studies going on in patients with atrial fibrillation and BNP values, seeing whether a high BNP value has an indirect effect on the recurrence of atrial fibrillation. It is a predictor of sudden cardiac death and a response to cardiac resynchronization therapy, where you may put in biomedical pacemakers in patients with intractable cardiac failure. Also used in valvular heart disease. And like I said, BNP values are also used to prognosticate patients with pulmonary embolism. A high BNP value has a poorer prognosis for patients with acute pulmonary embolism. These are the conditions associated with an increase or decrease in BNP values. You have cardiac causes, hypertension, you have pulmonary diseases like embolism, ARDS, PH, acute and chronic renal failure, cirrhotic livers, sepsis, hyperthyroidism, female sex, older age, and lower than expected BNP seen in obesity, flash pulmonary edema, and in pericardial constriction. In pericardial constriction because the pericardium restricts the myocardium and does not allow it to stretch. Also been shown as a prognostic marker in acute coronary syndrome, higher risk of death at 10 months, as with increased concentrations of BNP 40 hours post-infarct. Also associated with an increased risk for new or recurrent MI. So high BNP value in an acute infarct patient has a poor prognostic indicator. The PRISM trial was one of the first trials which studied the role of brain natriuretic peptide and the ACS risk assessment, where it said that NT-proBNP levels that were elevated from baseline at 48 and 72 hours were associated with higher event rates at 30 days. And patients with a negative troponin T but elevated NT-proBNP levels had risk comparable to the troponin T positive patients. I'll come to certain prognostic markers and markers of risk stratification, though they are not classical cardiac biomarkers. These are C-reactive protein, myeloperoxidase, homocysteine, and the GFR. I'm not going to touch on the GFR because that's an extensive topic as far as prognostic markers are concerned. A C-reactive protein is very commonly done in our labs today. And a lot of physicians ask for a C-reactive protein randomly in patients with a suspect coronary disease, and you'll end up with values which are high, and then you don't know what to do about it. It is used as a screening for cardiovascular risk in otherwise healthy men and women. Mind you, the problem is any infection can increase the CRP levels. You can have a dental infection and the CRP levels may go high. So a CRP level is, if it is high, it's a prognostic value only if the patient does not have any other source of infection. Predictive value of, the predictive value of CRP levels for disease, severity in pre-existing coronary disease, and has a prognostic value in acute coronary syndromes when you do regular CRPs on a twice or thrice weekly basis to see whether the levels are coming down with treatment or not. Is it a risk factor or is it a risk marker? Previously, it was known to be a risk marker for cardiovascular disease, but there have been certain studies which now implicate CRP as a risk factor for coronary disease by it should be a reduced nitric oxide synthesis by causes endothelial dysfunction, reducing the nitric oxide synthesis. And there's an increased LDL deposition in the plaque, especially by CRP-stimulated macrophages. So it basically has a role as a risk factor also. What are the increased cardiovascular risks when you have a high CRP? You have a long-term risk of first MI, ischemic stroke, vascular disease, and all-cause mortality. And this relationship persists even when the data is adjusted for the classical risk factors, including smoking, hypertension, lipids, diabetes, etc. The limits or limitations of CRP screening, of course, like I said, is a low specificity. It's not specific of cardiovascular disease. No evidence that reducing the CRP levels actually reduces the cardiovascular risk. And some medications do lower the CRP levels, but we're not sure what the long-term implication of that is in terms of reducing the incidence of cardiovascular disease or reducing acute coronary syndrome events. The current recommendations of CRP are that it's not useful as a public health measure. Screening of the entire adult population should be avoided. It is considered the inflammatory marker most useful in clinical practice, useful in guiding further evaluation in intermediate risk patients of Framingham risk of 10 to 20% risk of developing significant coronary artery disease in 10 years. Homocysteine is another intermediary amino acid. Moderate homocysteinemia occurs, hyperhomocysteinemia occurs in about 5 to 7% of the population. It's recognized as an independent risk factor for the development of atherosclerotic disease, can result from genetic defects, drugs, vitamin deficiencies, or even smoking. Elevated levels do appear to be an independent risk factor. Screening is recommended in patients who have premature cardiovascular disease or a strong family history of cardiovascular disease, not as a routine. Treatment, folic acid, vitamin B6, and vitamin B12. There are certain markers of chemotherapy-induced cardiac damage. We see a lot of patients with chemotherapy coming in with cardiac damage. So traditionally, left ventricular LV ejection fractions, angiography using radionuclide methods, or an endomyocardial biopsy have been used to assess and monitor chemotherapy. However, studies have shown that certain cardiac troponins, cardiac natriuretic peptides, and brain natriuretic peptides, the CNP and the BNP values, have some role in the assessment of cardiotoxicity. But again, we have no current guidelines which give us any specific recommendations as to which biomarker is specific and sensitive in terms of marking out chemotherapy-induced cardiac damage. These are certain newborn markers which are still not being proven to be useful. Their usefulness is still in the trials. There are certain genomic markers which are useful in doing a gene study in these patients. And of course, I come back to the same slide where we're still in search of a typical marker which tells us whether the patient has an acute coronary syndrome or not. The ones that rise early, like I said, are less specific. The ones that rise late are more specific, but they give us a lot of time gap in between the onset of symptoms and the detection of the rise of markers. The IMPACT trial and the PREDICT trial are two trials which are ongoing trials. The IMPACT trial is on atrial fibrillation. The PREDICT trial is on chemotherapeutic agents and the role of biomarkers in both to predict the recurrence of AF and in predicting chemotherapy-induced cardiovascular damage. What are the future prospects? The future prospects here would be advances in understanding the molecular basis of disease, which has provided new opportunities to develop biomarkers and genome-based tools which are used to diagnose, predict disease, the onset of recurrence, and tailor the treatment options to these patients. The future answer may be in a fully automated platform which is capable of both biochemical and genomic markers with equal analytical efficiency and capabilities. If I were to conclude, I would say that cardiac biomarkers do play an important role in the diagnosis, prognosis, prevention, treatment, and monitoring of cardiac diseases. With the new insights into pathophysiology and molecular basis of disease, various molecules and genetic markers are now evolving as putative markers of cardiac disorders. At the present time, we have tested markers like troponin T and CPK-MB, which are frequently used because they're easily available. They are pretty easily diagnosable. They are supplanted by markers like BNP and NHS-CRP in terms of, in most of these situations, but dictated by the clinical settings. But we need to know when to do these investigations and when not to do these investigations. More importantly, we also need to realize that investigations can never replace clinical skills and acumen in diagnosing and treating any disease. And investigations are only a helpful additive tool in patient management and have to be used in conjunction with the detailed history and clinical examination. There were two proverbs: diagnosis is not the end, but the beginning of practice. And more importantly, rather than multiple investigations, if you sit with the patient and get a proper history, 3 simple questions, and 1 well-chosen laboratory test, which can lead to an unambiguous diagnosis, why harry the patient with any more? Thank you very much.